Okay, so we've talked about dysrhythmias originating in the SA node and the AV node. Now we're going to talk about the AV junction. So we've gotten a little further down in the conduction system to the AV junction, and if we remember from normal conduction, there's a slight pause at that AV junction to allow for ventricular filling. And so now if we've got an extended pause, something beyond the norm, we're going to talk about the ways that can affect circulatory perfusion and how we're going to have problems if we start to have blocks. So this is where we get into our blocks. Our AV blocks locations at the AV node at the bundle of His and possibly below the bundle of His. We've got four types that we need to focus on and be aware of. A first degree AV block, a type 1 second degree, type 2 second degree, and a third degree or complete AV block. We're looking at the photo to the right, or the image. Internodal pathways are coming in from the atria and the SA node. They come into that AV junction. They're all together at that spot, and then we've got a ventricular septum, if you will, coming down to where it bifurcates into the right and left bundle branches into the Purkinje fibers. And now we're going to talk about why there might be a problem in that tissue or a cause for blocks. So our first degree AV block, this is a lengthening of that PR interval, and so that's going to be the biggest thing we notice here. So our rate depends on the underlying rhythm. Rhythm is usually regular. SA node or the atria is the pacemaker side, so up high, but we've got good P waves, so we know that it's originating up that direction. But look at our PRI interval. If you just take a quick glance at this particular image, this is a pretty good representation of first degree block. And if I count on this first one, if I use my red highlighted red boxes, I'll look at that, and then I go across to our Q wave, and if I look at that, I'm sorry, to the P from PR, I look at that first box, and man, look at that, I'm way outside of that red box. So taking a quick glance at it, it may be hard to see on a monitor, so it's nice sometimes if you print a strip off and use that as your basis, but we're definitely greater than 0.20 seconds on this guy. And if it's regular, everything looks like it's supposed to be, but you've got a lengthening of that P wave, taking a little bit longer to conduct that electrical impulse into those ventricles. So that's what we've got an issue there. And then the QRS is usually less than 0.12, so we've got good conduction once it gets past that block. So why is it happening? We've got a delay in the conduction through the AV node. May occur in healthy hearts, but often indicative of ischemia, some kind of physical block there at the AV junction. Usually not significant, but new onset may precede a more advanced block. So this is kind of a slow tap on the shoulder, like, hey, we may have an issue here. There's generally no treatment that we're going to provide. We're not going to do anything unless they're symptomatic. If it's a really slow rate down in that bradycardic rate where the patient may be dizzy or have a low BP or chest pain, short of that, we're really not going to do anything for it. Avoid drugs that may further slow AV conduction. So anything that would cause that to slow down, we don't want to throw them on top of it. A type 1 second degree, also known as Mobitz 1, the rate is atrial, normal ventricular rate, normal to slow, just depends on what's conducting. The rhythm, atrial again, regular. The ventricular is irregular. Think about your pacemaker site being in the SA node or atrial area, and then we're conducting, but some of these beats are not making it where they need to go. And this is kind of one of those things that is not best represented in this slide, but if you'll notice here, the first complex, here's a P wave, it's getting a little longer until it actually drops. Let's look at this next one. P wave here, QRS, a little longer distance, a little longer distance. The PRI interval just keeps getting longer and longer until it eventually drops. So the way I could remember this through school is, since it's Winky Bach, is another name that we use for type 1 second degree. We say longer, longer, longer drop, Winky, Winky, Winky Bach. That's just one way to remember that term, but it's type 1, second degree. P waves normal, some P waves not followed by a QRS, so you've got a drop beat. Increases to the QRS's drop, and then it repeats, so it's systematic. It just each time those P waves get a little bit further down. And the QRS is usually 0.12 seconds or less, so it's conducting down and the ventricles are squeezing. Again, Mobitz 1 or Winky Bach, I can remember Winky Bach better. Delay increases until an impulse is blocked, indicative of ischemia at the AV junction, so we've got a choking or a problem there where we don't have good perfusion. Frequently drop beats can result in cardiac compromise, so generally there's nothing that we do on a regular basis for this, but we need to observe the patient, make sure they don't get into a more dangerous block. Again, don't want to provide any drugs that further slow that AV conduction, and then treat any symptomatic bradycardia. If they're experiencing the things I mentioned earlier with the low BP or chest pain, then we might want to consider speeding that up with maybe atropine. Type 2, second degree. So getting a little bit worse here. Atrial is normal, the ventricular is slow, so our atrial impulses are happening, but the ventricular are not. Or at least not following through every time. The pacemaker state is still up high in the SA node or the atria. P waves are normal, some P waves not followed by a QRS. So you've just got occasional P waves that are laying out there in the middle of nowhere. So here's a P wave, no complex. Here's a P wave that's lengthened, the QRS complex, a T wave, and then here's another P wave, no complex. P wave, no complex. P wave, no complex. And what I'd like to do is, if I had a piece of paper, I would measure from this P wave you see here, that little bump is a P wave, to this P wave, and measure across, and then I can predict my next P wave. So there's my next one, there's my next one, there's my next one, and there's my next one. So we just follow all across. So we've got atrial depolarization, but it's not catching or capturing in the ventricles. So we've got a PRI that's constant for the conducted beats. Out of those three complexes you see on that strip, all three of them have the same PRI interval. They're long. They're definitely in that first degree range. But now we've got a complete a P wave that's thrown out there. We have an atrial impulse, but it's being blocked every other beat on this particular strip. Again, those conducting beats, the QRS, we do have good push, but this is very slow. If this was a 6-second strip, we're times it by 10, this would only be 30 beats per minute. Also called Mobitz 2 or infranodal, intermittent block of impulses, usually associated with MI or septal necrosis. So we've got actual damage that's being taken place here, usually with an MI. May compromise cardiac output. I'd say so if we only had 30 beats per minute. Often develops into full AV blocks, so this is where you've got to be worried about a patient having a massive MI and that heart rate slowed down. We're not conducting beats to the ventricles anymore. Those pathways are being cut off electrically because of the death of those tissues or those cardiac cells because of the block in the vascular system. So we avoid the drugs that are going to slow things down again, treat symptomatic bradycardia, and this is where we've got to get a little careful about whether we want to speed them up with atropine or not. And then consider transcutaneous pacing. And this is where another tool we're going to use on that cardiac monitor, where we place the defibrillator pads on the patient, and then we would consider pacing the patient. In other words, we're doing it artificially through the skin, where we get the transcutaneous part, and we're going to do it externally. So we will actually be pacing through those pads to the patient. So now we've learned how to defibrillate the patient. In other words, stop all cardiac activity. We've talked about synchronized cardioversion, where we apply a set amount of electrical activity to knock out a dysrhythmia, and then we're actually using the monitor to electrically stimulate the heart to beat. So now we've got three tools, or three uses of that cardiac monitor that y'all have been introduced to now. So that third degree AV block, this is also known as complete block. The rate is normal for the atria, but and then 40 to 60 beats on the ventricle. So this is where we have a complete disassociation between the upper part of the heart and the lower part. In other words, the atria are doing their thing, the ventricles are doing their thing. They're not even talking anymore. So electrically, it's just like a dam has been built between the two. As far as the rhythm goes, both the atria and the ventricular are regular. So if I took a piece of paper out and I marked the top of the R wave on this QRS and the top of the R wave on this QRS, and I carried them across to each one of those ventricular complexes, then I know that those beats are regular. If I took a same piece of paper and measured from the P waves, I would get the same distance between each of those P waves, and some of those P waves are buried in the complexes, so you can't quite see all of them, but you've just got a complete disassociation. They're not even on the same page anymore. So pacemaker site, again, SA node and AV junction or ventricle, so it just depends on where that could be. P waves normal with no correlation to QRS, so they're upright, they're normal, but they're not talking. The PR interval, no relationship, so you can't even count it. It doesn't even match up anymore. And the QRS is 0.12 seconds or greater because it's originating somewhere down in the ventricles. So why does a third degree block happen? Absence of conduction between the atria and the ventricles results from an AMI, could be DIG toxicity, or just a general degeneration of the conductive system. It could just happen as part of life or nature. You've got severely compromised cardiac output because think of it as you've removed a spark plug in that engine now, and it's not even firing right anymore. Transcutaneous pacing for acutely symptomatic patients it may be what our definitive care in the field is going to be. But really, these patients, the fix for this is to go in and have a pacemaker implanted. Treat any symptomatic bradycardia. Avoid drugs that may further slow AV conduction, so we know about that. Dysrhythmia is sustained or originating in the AV junction. We could have premature junctional contractions, or PJCs, junctional escape complexes and rhythms, accelerated junctional rhythms, and paroxysmal junctional attack. Some of the characteristics you may find, it may be an inverted P wave in Li2 because it's developing or sending out that electrical impulse in a different direction. The PR interval of greater than or less than 0.12 seconds, and then normal QRS complex duration because it's conducting to the ventricles. Now, out of these dysrhythmias, there's 4 that are listed there. Typically, we focus more in the AV junction problems on the 4 blocks that I mentioned earlier. These are something that you can just look at. So PJCs depends on the underlying rhythm. You've got one PJC that's popping up there after about the 7th complex or so. The rhythm depends on the underlying rhythm. You've got an ectopic focus in the AV junction. P waves are inverted, so you notice these they're down slope. PR interval normal if P wave occurs before the QRS and the QRS is still conducting properly. Maybe because of a single electrical impulse that's originating in the AV node, it may occur with caffeine, tobacco, and alcohol use, so it could have heart disease, hypoxia, DIG toxicity, or it may just be something the patient has or was born with. Limited frequent PJCs, as far as its significance is limited, frequent PJCs may be precursors to other dysrhythmias in that area, so typically our treatment is none. Junctional escape complexes, rate is 40 to 60. So notice the difference on this slide here where you've got your junctional, the little star there is your originator, and now it's actually conducting upwards completely in the backwards direction. The rhythm's irregular. Notice on this strip there's no P waves in front of those complexes. The pacemaker sites in the AV junction, they're going to have inverted P waves. If there's a normal P, it's going to occur before that QRS, and then the QRS is typically the normal amount. So this is a slow rate. And go back to your initial cards. Remember, in the upper SA node, we're going to pace at 60 to 100. In the AV junction, it's going to be 40 to 60. and then the ventricles it's 20 to 40. So just remember those rules. Results when the AV becomes the pacemaker site. This is could be an increased vagal tone. So somebody that's got an increased vagal tone, they could have thrown them into this. Pathologically slow SA node discharges or heart blocks. So just could be a multitude of things. The slow rate may decrease cardiac output, precipitating angina or other problems. Treatment is not anything particular unless it remains, if they remain asymptomatic, but we may want to speed them up with atropine or pacing if needed, if it's too slow to perfuse. An accelerated junctional, remember that anything over that junctional area, anything over 60 is our key for accelerated. So we're over 60, the rhythm's regular, AV junction is in the pacemaker. So in other words, we talked about SVT up in the atria hanging and getting too fast. Well, if our rate, intrinsic rate for the AV junction is 40 to 60, and we hang in there at a faster rate for that pacemaker site, then we're going to call that an accelerated. P waves again are inverted. PRI normal if the P occurs before the QRS and the QRS is still conducting normally. So results from an increased automaticity often occurs due to ischemia. It's usually well tolerated, but monitor for other dysrhythmias. So there's generally nothing that we're going to do in the pre-hospital setting for an accelerated junctional rhythm, as long as they're perfusing well and not in pain and breathing. Paroxysmal junctional tach. Your rate, again, 100 to 180. Rhythm is regular. It's in the AV junction. P waves are going to be inverted again, as you can see there on that page. Normal PR interval if P occurs before the QRS and the QRS is conducting well. So we've got, remember, paroxysmal may mean that it's going in and out of this, but anything over that that rate there is that tachycardic rate. So it's rapid depolarization in the junctional area. It overrides the SA node. It can occur with or without heart disease. It may be a stress issue, overexertion, tobacco, caffeine, just depends. May be well tolerated for brief periods, so the patient may be able to deal with this for a period of time, but you're going to have decreased cardiac output from a long episode. So you're going to have chest pain, low blood pressure, maybe fluid buildup in the lungs. And paroxysmal junctional tach, we really kind of think of it the same way as SVT. You want to go with the vagal maneuvers first, your pharmacological with the IV of 6, 12, and 12 on your adenosine, and then move into electrical therapy if their rate is over 150 and they have a low or no BP or radial pulse. We go back to that synchronized cardioversion. And that concludes.